So today we have with us Ms. Sukanya Ray. She is an experienced clinical psychologist with almost 18 years of experience now. She has done her MPhil in clinical psychology from NIMHANS, and at present she is working as assistant professor at School of Human Ecology, Tata Institute of Social Sciences, Mumbai. She's a psychotherapist, a supervisor, academician, and some of the area of her work and specialization which she focuses is she has designed and anchored several courses on trauma informed care. So she's focused on trauma focused therapy, animal assisted therapy in counseling and courses on substance use and addictions. And she is also member of EMDR International Association, IFS Institute USA, Internal Family Systems, and a lot many things to her credentials. So we welcome you, ma'am, and we are really, really excited to hear your talks. So we'll also make you the co-host, so you could share your PPT with us.
Yeah, I have already made her the
Okay,
host.
okay. Welcome, ma'am.
Thank you, Nidhi. Thank you, Manisha. Thank you, Dr. Palan, and especially Dr. Prashant Kumar Roy for inviting me to this occasion today. Congratulations to the Academy of Hypnosis for completing 3 years. This is, of course, just the beginning, and I hope that we get to see more years and more such foundation days the decades ahead. I hope I'm audible.
Yes, ma'am.
Okay, all right. Shall I start or shall we wait for a few minutes?
Ma'am, we can start.
Okay. So I'll just, okay, it seems I can't share.
Please try.
Now I can share. Thank you. All right. Hope this is visible. Okay, all right. So I have been asked to speak briefly on trauma and hypnosis. As Nidhi introduced me, I'm a trauma therapist. I have completed certification in several trauma-focused approaches, including EMDR, internal family systems, clinical hypnosis, ego state therapy, and other such approaches. What I'm going to talk about today is not just about trauma-focused approaches or not just about the hypnotic techniques that we use in treatment of trauma and dissociation, but I intend to cover a little bit more. Of course, this is a topic which can go on for days, if not years, because there's a lot of literature, almost more than a century of work that was started by Jane. And so there's a lot that can be discussed, especially in an August environment like this. But of course, we need to be brief, we need to be succinct. So I intend to cover these objectives in the next 1.5 hours. So I'll walk the audience through the meaning of trauma-informed work. And this is important because I think the whole idea of trauma has evolved in the last 100-odd years. And so it's important to understand the contemporary approach to trauma-informed work and what do we mean by trauma. Whenever we talk about trauma, we cannot not talk about dissociation. So the next the subtopic would be trauma and dissociation. And finally, we'll talk about how we use hypnosis in the treatment of trauma and dissociation. So that's going to be the overall plan. We'll have some time, hopefully, towards the end for any curiosities, questions, etc. So I begin with, like I said, just a discussion of what is our contemporary understanding of trauma. This is how we have learned to view trauma. This is, of course, the clinical lens, the PTSD lens, the ICD lens, or the DSM lens, which looks at traumatic conditions or trauma-related disorders as related to an event. Now, this event has been defined, with a sense of danger to the self or others, or a acute sense of helplessness. And this is the cornerstone of any traumatic experience, as has been defined in our classification systems. However, as trauma therapists, when we are looking at presentations, we are we find that these discrete categories, PTSD, and even the ICD-11 category of complex PTSD, do not suffice because the complexity is enormous. So we often fall back on, and probably among trauma therapists, the diagnostic categories which are used the most are the disorders of extreme stress not otherwise specified, or in other words, DSNOS, or dissociative disorders not otherwise specified. This sheer fact that we end up diagnosing individuals who come to us with complex trauma with these two diagnostic categories tells us that the story of PTSD and CPTSD or complex PTSD is not complete in itself. There's a lot that needs to be understood in terms of what is really going on. So these symptoms, the intrusion symptoms or the avoidance symptoms or the alterations in cognition, mood, reactivity, these are cornerstones that we know already. But like I said, that we need to increase or enhance the ambit of what we are defining as trauma. So with the work of Judith Herman and others as well in the 1980s, 1990s, Judith Herman is a psychiatrist who has worked extensively tracking the women's rights movements in the US and thereby, bringing to the fore the kind of traumatic experiences that women and children have had. And that really is reflected in her work, Trauma and Recovery. And she introduced the word complex trauma. And from there, we sort of have started to understand that there's a lot more going on than just one event which can be described as life-threatening or having the other cornerstone symptoms that we see in DSM-5 or the DSMs and ICDs. So the trauma-informed lens has come from research in the US, which has looked at, the adverse childhood experiences, which is something I guess we all are informed about, and that sort of has helped us understand that trauma is not about what happened or if something happened. So as a trauma therapist, we are taught that I don't need to know, as a therapist, I don't need to know what happened to the client or whether something happened. So even though we have checklists, trauma symptoms checklist or ACE or any of these checklists, oftentimes when we are doing the work of trauma, we don't need to ask these questions about what happened to the individual. And it's also, counterintuitive because as we say, that what happened is often dissociated or forgotten. And so how can we expect the client who's coming in with complex trauma to give us a complete history of what happened to them? So this psychiatric lens of, the history of present illness, starting from past, as far back as the individual or their caregivers can remember, is important, but not the mainstay of treatment. So we often do not need to start treatment with a complete history or assuming that the history that we have is complete. So if it is not about what happened or if something happened, what is the trauma lens about? We often hear that the trauma lens is about what has stayed on or what part of the past is still the present. So there's a lot more emphasis on what's going on in the present for the individual. Symptoms, of course, also things that are, as we will learn, things that are implicit, not really in our conscious mind, but what are the memories, what are the images, what are the implicit processing that is available for description. Trauma as a force is transformative, for better or for worse, because we tend to look at, and the colloquial definition of trauma also focuses on something that is traumatic or something that withers away the organism. But trauma also has transformative potential, as we see in case of post-traumatic growth or any sort of traumatic impact on a living organism has a transformative impact. Trauma therapy taps at this transformative potential of the traumatic experience, which helps not only heal the wound but also lead to post-traumatic growth. So when we are looking at trauma, there are these 3 E's that we need to look at. So there can be the traumatic event or events or series of events or something that is continuing for some time. But that's not enough. So we also look at the second D, which is the experience of the event. So just like I said that, the DSM lens or the ICD lens really sort of focuses on what happened or the event, and that's not something that is enough to look at the trauma or understand the impact. So we need to look at the experience or what was the impact of the event. And this impact is, of course, subjective. We cannot define the traumatic impact with respect to the enormity of the event or the quality of the event or other indicators which might give us a sense of the severity. This experience is uniquely subjective, and it's something that can only come from the individual who's with us. Now, the experience. Now, the experience again is not something that will help us to look at the look at the impact of it. What is important is what effect or what lasting impact did this experience have, or what part of this experience is continued into the present. So that's exactly what we mean by what of the past is still the present. We often see that in the present, when we tap into the effect of this experience that has continued into the present, and we often see that what has stayed on is the overwhelming impact. There's a strong negative impact of it. And there is a pronounced sense of helplessness, powerlessness, loss of agency or control, and a sense of being vulnerable. This is often pronounced. Many a times it may not be pronounced in terms of what the patient is verbalizing, what the client is verbalizing, but oftentimes it's evident in the implicit behavior that we are noticing. And this is something that requires a lot of training to be able to capture the implicit impact that has stayed on. Because as we will learn that trauma is not in the narrative, it's not often in what is remembered in the narrative, but often in terms of what is not remembered. So it's not the event that is important, it's the experience and the effect that we need to tap into. So this is why questions on what happened are not important, and it can be re-traumatizing. Instead, we learn to ask questions like, when you remember that now, what are you experiencing? Or when you are recalling that event, or when you're telling me about it, what is it that you're experiencing now? These questions are far more important than the kind of questions that we ask for eliciting history or eliciting what happened to the client. Janina Fisher talks about how trauma is stored as implicit memories and shows up as symptoms. And these symptoms, as you can see from this image from Janina's resources, that this is, this covers the entire gamut of psychiatric symptoms and psychiatric diagnostic categories, right from depression to a sense of loss of identity, somatic symptoms. And here's what we see, that the impact of trauma is not just visible in the PTSD-like symptoms, but a lot of these nuanced and implicit ways in which trauma recall happens. And many a times, trauma survivors may not have explicit memories that they can narrate out, but what they display are these various symptoms which can transcend diagnostic categories. So I won't go into a lot of details about the complexity of trauma, but I think it's important to talk a little bit about complex trauma. And often we hear this sort of discussion that how can everything be about trauma? But the problem with that limited view is that when we say everything is not about trauma, we are again falling back on trauma as a diagnosis or the PTSD lens. Because when we look at the whole idea of complex trauma, as Judith Herman had put forth, we see that it's really in the little things of life. It's not about the big events, but it's in the enduring conditions. And I'm sure we'll all agree that we are living through a lot of enduring conditions right now, which are overwhelming. And we might be compartmentalizing that sense of overwhelm. We might be switching off the news or not looking into details of it. We have adapted to what's going on in the world, what's going on in our surroundings. But this complexity of traumatic stressor is everywhere right now. It's multi-layered. We notice this in different systemic forces that operate upon us, racial, intergenerational, interpersonal, intrapersonal as well. Research in the US shows that trauma is pervasive, and that even when we look at it from the traumatic event lens, 55 to 90% have experienced at least one if such event, which can be defined as a traumatic event. And on an average, 5 traumatic events in their lifetimes is what most people experience. Now, this insidious impact is broad, it's deep, it's life-shaping, and it's something that doesn't always show up in how we are remembering our narrative or how we are remembering our lives. The other issue with the kind of complexity of traumatic stress that we are living through is that violent trauma is often self-perpetrating. And I'm sure we'll all agree that when we are looking at someone who is a perpetrator now, is someone who has been on the receiving end sometime back. So, unresolved trauma is something that will always be passed on, whether it's in the family or the next generation, or throughout the geography as well. So violent trauma is often self-perpetrating, and which is why this complexity of trauma is what makes this pervasive enough. And we can safely say that we probably find very few people in the world who do not have this level of traumatic stressors that they've experienced in their lives. Since we don't yet have a diagnostic categorization of what complex trauma is, like I said, that complex trauma as the term is different from the diagnostic category of complex PTSD, which has been introduced in ICD-11. And when we look at the lens of complex trauma, pretty much all diagnostic categories can fit into that lens. We can reconceptualize every such clinical presentation through the lens of trauma. Of course, it's not something that we'll go into today because that's outside the purview of today's talk, and it requires a much longer deliberation of sorts. So we most often, we say this, that very often these days, 95% people are aware of the trauma, and the remaining 5% are still not aware of the traumatic stressors that they have been living through. So we can safely say that is the social reality of our times, the kind of multi-layered traumatic stressors that we are subjected to. It's far more common and deep than just being a diagnostic category. And there are risks inherent in traditional talk therapy approach, because traditional talk therapy approach can take up a confrontational stance, which can be inherently re-traumatizing for someone with complex trauma. Not only can it be re-traumatizing for the client, it can also be re-traumatizing for the therapists. And so it's important for clinicians, especially psychotherapists, to have this lens in the modern purview of working with complex trauma. So the trauma-informed approach, which was basically introduced in the 2000s by Palan and Harris, is a paradigmatic shift, because it moves away from problematizing the individual, from asking questions and sort of diagnosing an individual with what's wrong with them, to a more compassionate stance of what happened to them, what are the experiences that have shaped them. But as a trauma therapist, we have also learned that this doesn't really mean that we ask this literal question about what happened to you. Because asking such a question that what happened to you is inherently re-traumatizing. So instead of this approach that what happened to you, the stance that we take is what has stayed on with you. What of the past is still living in you into the present. So we don't literally ask the question, what happened to you? We learn to ask the question, that, like I said, that when you're recalling that, or when you're recalling this part of your life, what are you experiencing now? This present moment, this word is something that really anchors and pronounces the whole idea of trauma-informed lens. So complex trauma, as we see, is qualitatively different from PTSD, and we can think of simple PTSD as one end of the spectrum, and what has been shown in complex PTSD, or what is implied in the term complex trauma, is on the other end of the spectrum. What we see on the other end of the spectrum, where the complexity of the stressors, the traumatic stressors, increases, is that we see a lot of dysregulation, or a lot of, as we say, disorders of self-organization. What we also see as we move from the left to the right side of the spectrum is that there are less resources available to the personality. So when we diagnose someone with simple PTSD, we are not only diagnosing them in terms of the kind of traumatic stressor that they have been subjected to, but also the kind of resources that the personality has, which would contribute to their sense of being stable enough to go through the therapeutic work that is required for healing. As we move towards the right hand side, because there are disorders of self organization, we see less of these resources in the personality. So, inherently, what we notice are signs and symptoms of an unstable personality disposition. We see problems in self regulation, we see more of pathological dissociation, we can see self harm behaviors, suicidal behaviors, substance use addiction issues, relational instability, etc. These are inherent, these are symptoms that are noticed in the complex trauma conditions, and we will sort of look at this a little later in terms of what is really increasing as we move from the left to the right side of the spectrum. I thought this is important for us to really differentiate, because there is trauma informed and there is trauma focused approach. Now, trauma-informed approach is a larger systemic approach that is applicable to larger systems or whole systems. So whether it's a school, an organization, or even legal systems, etc., trauma-informed approach can be adopted by entire systems, whereas trauma-focused approach requires a lot more specialization. And as you can see that both approaches focus on developing resources for the individual, and both approaches are based on appreciating the strengths in the individual, or a more salutogenic approach to the individual, not just in terms of the disorders approach or the pathologizing approach. But where trauma-focused approach differs from trauma-informed is that trauma-focused also goes into the deeper healing of the attachment wounds or the traumatic wounds from the past. Of course, this means that this is going to be a time-intensive approach. It requires a lot more specialization for the professional who's involved in the healing, and a lot more nuanced, layered, and time-intensive strategies that are involved. So while we are talking about trauma-informed and trauma-focused, it's important to understand that the different kinds of therapies and techniques that are there for working with trauma and complex trauma may differ, because trauma-informed approaches may take a much more preventive, symptom reduction approach, but trauma-focused approaches will take a much more incisive view and engage in the healing rather than working around the trauma. Just like in hypnosis, we use hypnosis for symptom reduction, and we also use hypnosis for deeper healing. So it's similar to that. I want to introduce the next segment with this beautiful poem. Maybe we can all read it from the screen. I thought this poem beautifully kind of encapsulates how our memories work, how our memory systems work. And I often say this when I work with individuals, when people ask me, what is different about your approach, Sukanya? What is it that you do differently? You say you don't do talk therapy. So what is it that you do differently? In a crux, I say that I work with memories. I don't work directly with thoughts. I don't work directly with beliefs. I don't work directly with emotions. But I work with all of them via memories. So trauma-focused work is really fascinating, because there's so much of neuroscience involved there. That there's the whole idea of how our memory systems work and how we can actually correct or edit the memories that need to be edited. So this approach is something that is fascinating because it also tells us how our memories operate on the principle of dissociation. So we'll start the next segment, which is on trauma and dissociation. Like I've said earlier, that discussions on trauma are incomplete if we do not talk about or touch upon the concept of dissociation and how these two are very intricately tied. Now, these are some of the clinical signs of dissociative disorders as we see in our classification systems, depersonalization and derealization, which are more extreme forms of dissociative symptoms. On a lesser pathological severity are symptoms such as memory lapses or flashbacks and significant intrusions. Even Schneiderian symptoms can be viewed as dissociative symptoms. Somatic symptoms, sleep disorders, affective disorders, or sometimes clients present to therapy for years but without much progress. So these are certain signs that we are probably looking at an underlying dissociative condition or severe degrees of dissociation that are operative. Now, why is this important? Because the more dissociation that is there, the more we need to use therapy that is dissociation informed. Therapies that are not dissociation informed or do not treat the dissociation may prolong the course of therapy or also lead to stuck points or impasses in the therapeutic process. So what is dissociation? There is dissociation as a diagnostic category, and there's dissociation as a phenomenon. What we're talking about right now is dissociation as a phenomenon. So dissociation as a phenomenon can be looked at as a mental stealth strategy. This is how the mind or the nervous system learns to or adapts this way of stealing information and hiding it. This is a mental stealth strategy that is adapted by the mind to protect the rest of the mind. This is the mind's practiced way of hiddenness. It is also the opposite of mindfulness. So if mindfulness is about all corners of the mind being lit, dissociation is the shadiness of the mind or the different light and shade that we see in the territory of the mind. Dissociation is the ability to both narrow down the field of attention as well as serve as a defensive function from overwhelming information. It's this capacity to compartmentalize experience that can be looked at as the sheer capacity to dissociate. We all dissociate. We all have the capacity to dissociate, just like we say that we all have the capacity to be hypnotized because we all have the capacity for trance. It's in the small things. Dissociation is evident in the small things. It doesn't always show up in big ways or as a clinical sign. So which is why when we are working with complex trauma, we need to be dissociation informed. This is a quote from one of the leading researchers and writers on dissociation and the proponent of the theory of structural dissociation, which is something that I think a lot of parts work approaches and trauma-focused approaches rely on. Onno van der Hart says that dissociation is the division of the patient's personality into parts that each have their own sense of self and experience too little or too much as a consequence of non-realization. These paradoxical experiences are the hallmark of the inability to realize trauma. Now, this realize word here is not in the colloquial sense. Realization here and non-realization here refers to integration. How these different dissociated parts can be recognized and integrated as parts of the self. And when there is non-realization or there is more of differentiation and these parts cannot be owned, cannot be integrated into the sense of self, that's where we notice dissociated parts of personality. We're not going to go into the theory of it. This is a fantastic theory that we can refer to later. It's called the theory of structural dissociation. And it helps us understand how dissociated parts of personality can be integrated back to a sense of realization. Now, this is the spectrum that we were talking about, that the more we move towards the right side of the spectrum, the more we notice disorders of self, the more we notice problems in self-organization, etc. So I've just attempted to sort of put different diagnostic categories for us to trace and track the kind of dysregulation and the kind of dissociation, the severity of dissociation that we see as we move from the left-hand side, which is more of the single incident trauma or the PTSD kind of presentation, moving through mood disorders, eating disorders, personality disorders, through more dissociated conditions like DID, dissociative identity disorders, and also psychosis. So as we move towards the right-hand side, we are noticing more of severe dissociation, more pathological dissociative symptoms, more disorders of self-regulation and self-organization, and therefore more differentiation and more parts of personality that are segregated and don't have that bridge that helps these parts to realize that they're all part of the same personality, the same whole. Now, like I said earlier, that what is unspeakable or the traumatic impact is something that is stored very differently in the brain. It's not stored in the form of a narrative. It's not something that is known to the mind. It's not stored in the form of words. It's not there as declarative. So this is something that is very important for trauma therapists to understand, that the trauma is not in the narrative. It's not about what happened. It's not about what the client remembers. Most of it is something that exists as fragments, as shards of glasses that have not been integrated. And so it's critical to really understand the structure of our memory systems. As we know from cognitive psychology, that our memories have two different segments. One is the explicit memory, the other one is the implicit memory system. The explicit memory system contains declarative and episodic information, or information about the world and information about our lives. And this is what helps shape the autobiographical memory, or the narrative that encompasses our stories, what has happened to me, where do I come from, and my life narrative. But there's a larger memory system, which is much, much more powerful than the explicit memory system. This is the implicit memory system, which includes the emotional memories and procedural memories. The implicit memory is quite literally the how-to of survival. If you ask a mountaineering person, somebody who climbs mountains and very experienced someone, if you ask them, let's say that this person was about, had a near-death experience falling off from a cliff, and if you ask them, how did you manage to survive? We very often notice that they might not be able to give us a moment-to-moment account of exactly what they did, because that how-to of how they saved themselves from a life-threatening fall is something that's inherent in their skills, or it's very procedural. That's not something that they can express in terms of words. So similarly, our implicit memory system is the how-to of survival. There's something that does not exist in terms of words. And the implicit memory has a lot more impact on our explicit memory systems. There's a lot of information that goes up from the implicit memory to the explicit memory, influencing how we remember our stories. And yet all of it may not be explicit. There's very little information that trickles down from the explicit to the implicit. So in a sense, the implicit memory system is larger, deeper, and does not exist at the level of conscious awareness. Now, the implicit processing in psychotherapy involves bringing to the fore avoided emotions, and these avoided emotions then need to be turned into adaptive emotions. Now, this whole process is sort of very easy to show here on this diagram, but we all will agree that this whole idea of exposure to avoided emotions and then the challenge of transforming these avoided emotions into something adaptive is a real challenge of therapeutic work. So when we are looking at accessing these avoided emotions, we are really sort of looking at techniques that can help facilitate these implicit processes, these avoided emotions, which is where hypnotic techniques are used. And when we are trying to approach these avoided emotions, one of the important barriers that comes up is the dissociative barrier. So we may notice memory lapses, or we may notice parts coming up that are traditionally labeled as resistance in psychotherapy. And this dissociative barrier is something that needs to be worked through for us to move from avoided emotions to adaptive emotions. I'm sure that some of us who are trained in paths work approach and some of us who are trained in ego state approaches, we have heard this many a times that this growing multiplicity, a growing tune of multiplicity, that we are not single, one whole individual, but we have many parts of us, we all have parts. This is something that comes from the writing of William James, to even the writings of Freud, and then it's Ernst Hilgard who really sort of talked about this split, a vertical split and a horizontal split in the mind, which enables us to understand the difference between repression and dissociation. So if you think about a horizontal split, and we look at the subcortical structures as the split between the subcortical structures and the cortical structures, we see that this is the zone of repression. The limbic cortex, etc., is the zone of repression. The part above is the zone that is not repressed. Now, within that zone, if we have a vertical split, we have the conscious mind and the preconscious mind, which is towards the posterior part of the cortex. The posterior part of the cortex is therefore the part of the mind that is dissociated, which means that it's preconsciously available, but it's dissociated from conscious awareness and split away from any sort of conscious manipulation of information. Now, this whole idea of the executive ego, or the frontal part of the cortex, the conscious mind, is something that Hilgard talks about, and the hidden observers are in the posterior part of the cortex, or the dissociated part of the mind, as we talked about. These two mechanisms is something for us to really understand that when we are dealing with trauma and dissociation, we are looking at repressed material, we are looking at dissociated material, and we are looking at material that is available to students. Now, what are the characteristics of some of these dissociative ego states? Oftentimes, these parts of personality that are dissociated have their own identities and their own sense of self. They might even have names, they have a different age, they have different demographic characteristics as well. They have a characteristic self-representation, and it may not be aligned with the whole person and whatever their social location are. The parts can have very different self-representation. Parts can also have their own set of autobiographical memories, which are different and compartmentalized from other parts' memories. Parts may also have a sense of ownership of their own thoughts, feelings, and actions, and so on. And this ownership may not align with the whole ownership of the system. So when we are working with parts, we need to respect these boundaries. And oftentimes, the first level of difficulty that we experience is in naming parts, because parts often might be hidden, parts often might not be comfortable showing up as parts, they might be blended with the entire system. So these are common challenges that we find when we are working with parts. So how does hypnosis help in all of this? How do we, what are the different ways in which we structure therapy when we are working with trauma and dissociation? Many trauma therapies, and I don't have a slide on that, but I'll allude to that time and again. Many trauma therapies are, most of the trauma focused approaches, as we say, are built on different principles of hypnosis. But I'm going to start with this quote from Spiegel and Spiegel. Hypnosis is not in and of itself therapy, but it has great potential to facilitate a variety of therapeutic strategies. This is what makes hypnosis omnipresent in the therapeutic world. Like I said, that in most trauma-focused approaches, we use not one, but many principles of hypnotic techniques and hypnosis. Some of these are well acknowledged, some of these are not acknowledged. But when we are trained in hypnosis, we are able to notice some of those, borrowings from the hypnosis field. Now, when we are dealing with complex trauma and dissociation, it's important to be trained in working with trauma and dissociation and work according to the guidelines which have been published by ISSTD. The fresh set of guidelines might come in next year. The current guidelines are from 2012 and they are currently being revised. Now, this guidelines for working with complex trauma and dissociation is something that came up from a task force that looked at what are the ways in which trauma therapists were really looking at complex trauma and dissociation. And, the findings really showed a lot of alignment and congruence with what Judith Herman had talked about in her book, Trauma and Recovery. that there are 3 phases. Now, these phases don't necessarily have to be linear, which means that these phases can be something that we keep going back and forth within. And these stages are also an idea that Pierre Janet talked about long time back, 100 years back as well. So the first stage when we are working with trauma and dissociation is instilling a sense of safety. And of course, one might say that that's basic for all therapeutic approaches. We cannot initiate any form of therapy without having safety into the in the therapeutic system, which is within the client and the therapist. But here, what is important to understand is that safety here is not just about the therapeutic relationship, but also about instilling safety in the client's nervous system. So when we are working with trauma and dissociation, we not only are fostering a sense of safety in the therapeutic relationship, we are also actively teaching skills that help the individual to access states of safety, access states of emotional stability in their nervous systems. This stability does not mean that they don't get dysregulated. The stability means that they are able to return to a place of safety and stabilization. The next stage that we often go forwards is the actual processing stage, as we say, or in Judith Herman's words, this is remembrance and mourning. This is the part where we are no longer working at the symptom reduction level, or we're not just looking at safety and stabilization, but we're also incorporating actual reprocessing work. We are working with therapeutic approaches, trauma-focused approaches, reprocessing the traumatic memory. So this is where the traumatic memories are, sort of transformed. Like I said, that the avoided emotions are brought to the fore, they are transformed and help to become more adaptive in nature. So this is the stage where we typically see memory is being reconsolidated, or memory is being transformed to a more adaptive narrative. And of course, after all of this, because we know that trauma and dissociation goes hand in hand, so there's fragmentation, so there's a need for all of this to become reconnected, to become integrated. So the third phase is reconnection and integration, not just within the individual system, but also reconnection and integration with the outside, with the ecology that the individual is in. Trauma and complex trauma work needs to follow this guideline. So we cannot take a deep dive into reprocessing without teaching the client how to access states of safety and emotional stability. Nor is it safe to do that, because otherwise we'll be inviting a lot of re-traumatization. So this 3-phased approach, or this phased approach to trauma work, is something that we do regardless of the kind of approach that we are taking up for trauma-focused processing. Now we come to hypnosis in the context of trauma therapy. As we know, I'm not going into principles of hypnosis, because I'm sure that there have been previous speakers who have talked about that. So I'm just going to sort of walk us through how we use hypnosis in the context of trauma therapy or complex trauma and dissociation. As we know that hypnosis involves, or hypnotic strategies involve, focused concentration or focused attention. So this intense concentration has an impact on the dissociative fragmentation. There are parts of the mind that have been fragmented, that are storing information that has been compartmentalized. So these compartmentalized parts, or these compartmentalized experiences can be accessed with the intense concentration. And so the inherent hiddenness that we were talking about these dissociative parts, that hiddenness is something that can be addressed with intense concentration, because now we are literally turning the lighthouse, the light from the lighthouse, into those hidden corners and illuminating those hidden corners. And when we do that, if we are lighting something that has been hidden, then it's no longer dissociated, it's no longer fragmented, it's no longer something that has been stolen away. So we are throwing light on the hidden corners of the mind. In the process of hypnosis, we also create boundaries around certain ego states, and within that boundary, within that therapeutic time, and within that boundary as well, there is an abreaction that can happen of that part, the stored emotions, or as we say in the language of trauma work, that every emotion has a life cycle, and through the abreaction, the emotion completes its life cycle. And so within the boundaries of the hypnotic trance, or within the boundaries of the therapeutic session, within the boundaries of that dissociated part, this hypnotic abreaction leads to a sense of release of the emotions, but in a controlled way as well. So it doesn't spill over and impact the other parts. And yet, whatever needs to be expressed gets expressed. In the process, as we will see, we are able to restructure the trauma narrative. We are able to restructure the trauma memories. It's outside the purview of today's talk, but recent research on memory reconsolidation says that with the work that we are doing, there is a window of correction that can be done with memories, because for a very brief window, the memory trace becomes labile. And during that phase, we can rewrite the memory. And that's what literally happens when we are restructuring traumatic memories. We are helping the brain to reconsolidate memories. Which doesn't mean that the entire event changes, or an alternative narrative comes up. We remember what happened, but we have a new narrative as well, which gets superimposed on top of that. So this restructuring of traumatic memories is impossible without working with just hypnotic techniques, and we will see what kind of hypnotic techniques help us to do this kind of restructuring. Another important principle that we often see in hypnosis is we never work against parts. In fact, in hypnosis and trauma-focused approaches, we do not use the word resistance at all, because we feel that there's no resistance. Parts do not resist. Parts really have a good enough reason to come up with some sort of barrier. And as we say in trauma work, that you work with the parts rather than working against it. So this is where trauma-focused approaches really differ from confrontational approaches of talk therapy. And so we learn to work with parts, we learn to respect parts, we learn to give them all the salience that is required, instead of arguing with them or confronting parts or really coining that as some form of resistance. So this working with parts rather than against is one of the cornerstones of any sort of hypnotic procedure that is employed in trauma-focused work. Now, how do we use hypnosis in trauma-focused approaches? There is ego state therapy, and in ego state therapy, of course, hypnotic techniques is something that Watkins and Watkins have traditionally used to access ego states or access different parts of personality. Many of these hidden observers, as Hilgard talks about, or many of these dissociated parts are not accessible with usual conversational styles in therapy, and so they require hypnotic techniques to be accessed. There is also hypnotic language that is used across trauma-focused approaches. So whether it be EMDR or internal family systems or even somatic work, there is a lot of hypnotic language that is used all across these different kinds of trauma-focused therapies. And I'll cover a little bit of that to give us some context of what are we talking about as the hypnotic language. And then there are hypnotic principles. So these three aspects, as we will see that, some approaches of trauma-focused work may not directly align with ego state therapy, but they definitely have a lot of components of hypnotic principles and hypnotic language. Some trauma-focused approaches are almost derivatives of ego state therapy. So we see a lot of resonance with how ego states or parts are approached, or the kind of techniques, or even the kind of language that is used. So, which is what I'm going to cover in terms of hypnotic language. I think we have a following lecture on ego state therapy, so I'm not going to go into details of that. Ego state is something that was introduced by Watkins and Watkins, John and Helen Watkins, ego state therapy, theory and therapy. And ego state is defined as an organized system of behavior and experience whose elements are bound together by some common principle, and which is separated from other such states by a boundary that is more or less permeable. So we all have ego states. We're supposed to have ego states because our ego states are born out of our experiences. There is no limit to the number of ego states that we can have. we can have as many ego states as the kind of experiences that we have had. But each of these ego states will have some kind of boundary around the principles or the system of experience that they've had. So there can be ego states that are built on a sense of disempowerment or powerlessness, and then there can be ego states that are built on agency and retaining power in the system. So these sort of ego states are what we refer to in normal parlance as parts of the personality. When we are doing parts work, we are basically accessing different ego states, and like we talked about earlier, we are really getting in touch with the memories of those different parts and helping to heal some of those memories. Coming to hypnotic language, when we teach trauma therapy, one of the most important aspects of doing trauma work is using the right language. And this language is not just about the words, but it's also about the non-verbals that the therapist uses. So this involves qualities like cadence and rhythm in our language, in our tone, but also the three important aspects or qualities of hypnotic language is it's invitational, which means that we never instruct, we only invite. So I would never say something like, you need to learn to relax. Or I would never say something like, close your eyes and breathe. I would perhaps say something on the lines of, I wonder what it might be like to close your eyes. I wonder what it might be like to take a deep breath here. So that's invitational. It's not something that is instructive or prescriptive. It's something that invites the individual, that invites curiosity into the room. And this is critical in the language that we're using. Why? Because when we use a more persuasive language, where we are instructing the individual or we are sort of prescribing certain techniques, etc., we are also inviting parts to come in with their logic of not following that. So traditionally speaking, we are inviting resistance into it, which is a word, like I said, we don't use in trauma or hypnosis. We don't look at resistance. We look at parts that have the of logic for not followed through. And we need to respect that. So which is why invitational language inherently offers choice to the individual. And this, as we know, trauma is, is a malaise of empowerment, which means that individuals with complex trauma have been chronically disempowered. Their agency and their choice have been taken away from them chronically. So when we are using the therapeutic language, we need to give back this sense of choice and empowerment. Using an invitational language ensures that we are providing choice points to the individual at every step of the therapeutic work. So, as we also use in hypnosis as well, we'll often say that either this may happen or that, you may go this way or that. So it's important to offer different choices. And sometimes this choice is needs to be limited, because not having choice or having something that's very diffuse or having something that's totally unstructured can also be problematic. Just like people need choices, they need open choices. Having too many choices can also be problematic, because that can also invite ambivalence, and too much of ambiguity can send them into their trauma hole, as we say. So it's important to sort of have choices that give a sense of empowerment and at the same time is not too ambiguous as well. So if I use language that does not give that choice of either this or that and just leave it at that, it can be problematic. So offering choice, but in an invitational way, is what we often borrow from the field of hypnosis. A lot of techniques that we use in trauma-focused work relies on metaphors or visualizations, which is again the staple of hypnosis, that we do not use words in a more wordy way, but we use words to build images, to build the non-verbal, to get access to the right brain. And of course, the cadence and rhythm of the voice, the softness or the soft gaze, all of that, which is characteristic and which is very, very important to induce trance, is something that is common in all of the trauma-focused approaches. whether it be EMDR or internal family systems or any of the patchwork approaches. The right attitude, the stance of the therapist, which is powered by curiosity rather than inquisitiveness, which is powered by presence and persistence rather than pushiness, is something that, again, all these therapies are borrowed from the field of hypnosis. Spiegel talks about these 8 C's in treating PTSD with hypnosis, and these 8 C's begin with confronting the trauma. So we notice that the most common response to traumatic recall is that, oh, you don't need to think about it, or don't think about it, or don't talk about it, or you don't need to feel that. That's the most common response that survivors get from others. Within the therapeutic setting, it's just the opposite, because we are allowing individuals to actually access those hidden corners of the mind. We are allowing them a safe passage into that hidden part of the mind, the compartmentalized experience. So the first C is about really confronting it. Here, confront doesn't mean that we are confronting it with guts and valor, but we are really sort of going in very softly. We are accessing it with a lot more softer traits like curiosity and compassion and connectedness, rather than going in with a lot of force to just dig and see what's in there. Second C refers to condensation of the traumatic experience. Condensation here refers to that, traumatic experience, like we said, that it may not be a single event. Many a times when we are working with individuals and I'm doing the memory work, it's very difficult for individuals to come up with a single memory that they can be worked on. They will often say that it's like a blob of memories, because these are enduring conditions that they've lived through, something that has happened on a daily basis. It's not something that stands out in the memory as one fine day something happened. It's about the daily beatings or the daily disappointments that they have faced. And over a period of time, this is built into resentment, deep resentment of sorts. So these small T's, as we say, are often difficult to be defined. And so many a times when we are working, with the trauma-focused approaches, we often ask this question: what is the worst part of that experience as you remember it? And this question, where we are asking them to define what is the worst part, is really about condensing the material into a focal point which needs the most healing. Now, I've been taught by my teachers that this condensed part of the experience oftentimes does not follow our prediction. So, for example, I'm dealing with someone who has experienced abuse. And I might assume that the worst part of that experience is the abuse itself. But when I ask that question, what is the worst part of that experience as you remember it today? Oftentimes, the response I get is, it's not the actual abuse, but the fact that nobody noticed, or that nobody came for help, or that somebody invalidated the whole experience. So the worst part of the experience is not about what is predicted, or not what we think might be the worst part. It's surprising, and it's always subjective. So we need to ask this question: what is the worst part of that experience that you can remember now? That is the most trauma-informed way of asking what happened and what needs healing. Now, the third C is very, very important. Almost all kinds of traumatic experiences leave enduring shame in the personality. And this experience of shame acts like a glue for traumatic memories, because shame is one of the most difficult emotions to treat in psychotherapy. And so, when we are working with trauma-focused approaches which involve hypnosis, we are allowing individuals to really uncover these feelings and experiences of shame that are inherent, in a way that doesn't shame the experience of shame. It's a fine line that we are working on when we are working with shame, because many a times our natural response to shame becomes, oh, you don't need to feel shame, or a natural response becomes that there's no shame about it here. But that's a way of shaming the experience of shame itself. Rather, shame needs to be welcomed into the room. Shame is something that can be healed in community. shame again is a problem of hiddenness. The more shame we feel, the more isolated we want to get. So, the confession of feelings of shame or experiences of shame is something that, again, is a cornerstone of different trauma-focused approaches where hypnosis plays a very important. Consolation here refers to both, the patient's or the client's parts being able to console the traumatic parts. So, for example, if I'm doing parts work, and if I'm inviting the adult part or a regulated part of the client to console some of the younger parts or the traumatized parts, it can be that. Consolation also means that it's in the transferential process, or how the therapist assumes the role of consoling the traumatized parts of the individual. Conscious awareness of previously repressed memories. Now, this conscious awareness, like I said, that this itself brings to light some of the repressed material or some of the dissociated material. And this conscious awareness, again, helps build the integrated story, which is no longer fragmented, but is pieced together. It's no longer looking like shards of glasses, but it looks like, a mirror that has been brought together, a broken mirror, but then they have been brought together aligned with the fault lines. Concentration on the desired goal. So, like I said, that trauma is transformative, and it's on us to sort of turn the avoided emotions into adaptive emotions. So, concentration on the desired goal, which means that what is it that the client needs to return to? What kind of goals might the client want outside the therapeutic session? That's something that each therapeutic session needs to address. Control must be returned to the patient. So control both in terms of accessing adaptive emotions, accessing stable and safe states, like I said, but also control of recall of the memory. So containment strategies that we often use, again, which involves hypnotic principles, are strategies that we often teach the client throughout the therapeutic process, regardless of the stage that we are in. We talked about the 3 stages. So throughout the 3 stages, we are constantly actively teaching the individual to contain what all came up. Because if too much came up, that can be problematic as well, because it may really overflow outside the therapy session and go out of control for the individual. And finally, congruence between the content and the feelings. So this is where the integration happens. This is where we are allowing different parts of the personality to come together. Different parts of the experience also to come together. So the belief, the thoughts match the feelings, and there's a sense of feeling more congruent about the narrative of what happened and how they responded to it. So what is important here in all these 8 C's is that when we are using hypnosis, we don't individually address we don't individually use each of these 8 C's, but we weave it in the therapeutic technique that we are employing. Of course, it's outside the time boundaries of today's discussion to really sort of, look at an example of what this may look like. But whether we are using, like I said, I named a few approaches that I'm trained in. And in all of these approaches, we are noticing that in some way or the other, these 8 C's are being fulfilled, whether it's about confronting the trauma within the safety of the confines of the therapeutic room, whether it's about asking that question of what is the worst part of the experience as you can remember now, or whether it's about really helping the client to address feelings of shame, whether it's about consolation or having parts that can rescue or that can bring the traumatized parts into the present, or about integrating all of these parts or all of these different memories, returning control to the patient. All of these different aspects and elements are woven into trauma-focused approaches. Of course, when Spiegel wrote about this in 1996, it was only PTSD that was talked about. But right now, when we are working with complex trauma and dissociation, these are 8 principles which we constantly see that they are ever present through the different phases of the work. Hypnotic techniques which have been used. We often use a lot of techniques in hypnosis for just symptom reduction, and this is for really to sort of clear the pathway, to have some space. As I often use this metaphor, you're kind of freeing up the RAM. You're kind of freeing up the working memory, freeing up the RAM for some processing to happen. So some of these symptom reduction techniques typically involve relaxation procedures. For example, there's a safe, calm place. A lot of procedures that are based on imagery and scripts that are based on creating a safe, calm place for the individual or even parts. There's a conference table technique, which is about inviting parts into a room that feels safe enough. And so these different sort of techniques, which are built on the principles of hypnotic techniques, are often used to bring in more resources which are available to the individual and to reduce the kind of anxiety that is prevalent in the system. Then there's the split screen technique. So in this, we ask the individual to imagine that this event that they are recalling, it's as if it's playing out in front of them like a movie of sorts. So when we are asking them to project this movie onto a screen in front, we are inviting some distance between the individual and the narrative or even the visualization of what happened. So this distance is something which acts as therapeutic dissociation. It enables the individual to bring in resources with which they can look at the traumatic material. A variation of this is where we ask the individual to split the screen into two. The left side looks at the sinister part, or the parts that are the parts of the experience that were really traumatic. And the right hand side of the screen to really look at what were the adaptive parts. What is it that they did to help themselves at that moment? What kind of adaptive responses might have come up? It might be as global as they're running away from it or screaming or crying for help, or maybe just an impulse that came up in the feet. So some of these things that are built in also enables the individual to pendulate between the sinister parts of the memory and the adaptive parts of it. And this enables noticing what went unnoticed at the time of the trauma, which is that there's always some adaptation to it. There's some survival that enables the individual to survive to the present moment. So this distancing and pendulation is key in a lot of techniques that we use in the trauma-focused way of working. So then there's age regression. This is again something which is omnipresent in trauma-focused approaches. We are constantly looking at younger parts, traumatized parts, whether it's child parts, inner child parts, adolescent parts, or just younger parts. Parts work approaches like ego state therapy, IFS, etc. Do a lot of what is called fleshing out of parts, which means that we are really asking individuals to notice the qualities of these parts, their age especially, and we use hypnotic trance to really help individuals go backwards in time, regress back to younger states, younger age states. And when we are able to access these ego states, which are younger than the current chronological age, we're able to access the memories, the traumatic memories. And then we do the therapeutic dissociation to be able to heal some of those traumatic memories. So age regression again is something that is inherent in the way that we use trauma-focused approaches. And then there is affect bridge, which was introduced by Watkins and Watkins. And affect bridge again is something that is used in EMDR as well, where we use kind of trance induction to track back to other memories, especially younger times where they might have felt the same emotions or the same somatic affect as well. So these are some of the techniques, and like I said, that when we go back to that spectrum that we started it with, on the left hand side is PTSD, where we have more well-adjusted personality, there are more resources available. There is adaptive differentiation, which means that there is more scope for parts to feel one. So it's like a family of parts. There is a sense of unity among the parts, a sense of feeling like family. And the more we move towards the right-hand side of the spectrum, the more we see there's disorders of self-organization, etc. The more we are looking at pathological dissociation, where these different parts are really segregated, fragmented, with less sense of unity, less sense of belonging to the same system. And the work that we do in trauma focused approaches with hypnosis is that we bring in these parts together, or we integrate them back together. So the fragmentation that was apparent, because of which we were seeing symptoms of complex trauma, are going to get resolved, because now these different parts are no longer segregated, no longer unknown to each other, but are more accessible. The more severe the dissociation is, the more we are veering towards dissociative identity disorder and that kind of pathological dissociation, the harder it gets to integrate these parts. To the extent that with severe dissociative identity disorder, or what we call as polyfragmented DID, sometimes individuals may choose to live their lives with dissociative parts, and that's okay too. We are also moving towards times where we are learning to be inclusive about people with severe DID. So we don't always need to have that overarching goal of integrating parts. Sometimes parts want to stay as parts. They don't want to integrate back into a whole, and that's okay too. So I'm going to close on that note and invite comments and questions. Thank you for your attention. And once again, thank you for inviting me here.
Thank you so much, Sukanya. That was an amazing presentation. And I'm sure our audiences have some comments and some questions. If we can take few of them, they can put it on chat box, and probably I'll call upon one by one everyone's name so that we can have one question per participant, if that's all right. Not more than one. Hanji sir, please. Palan.
Question nahi hai, but beautiful,
Hanji.
wonderful. I appreciate your slides. Very, very beautiful and very, very meaningful slides. I appreciate just passing reference to state-dependent learning memory behavior. That subject attracted me a lot when I heard it from Dr. Rossi. He worked on it in detail. So thank you very much, Sukanya. It was wonderful. Lot of learning. I learned many things today. Thank you.
Thank you so much, sir.
So I do see a few questions in the chat box.
Yeah, I think there's a question: is dissociation distraction or distractibility?
Yes, ma'am.
Yeah, that's a very interesting question. Dissociation, of course, dissociation has the intent of distracting the system, and it can, as we say, that too much of trauma or too much of this mechanism of dissociating can lead to distractibility, high distractibility, which is then apparent as a symptom of ADHD. So definitely, it's tied to the quality of distractibility or the trait of distractibility. But I suppose dissociation does not mean distractibility as such, because it is a defense mechanism which is sort of intended to compartmentalize information for the betterment of the system, so that the system can function in an optimized way.
Thank you, ma'am. We have Dr. Sanjay Ratnaparki, sir. Hanji, sir. Sir, unmute. Please unmute yourself.
Yes, now it's possible. So good morning, really very excellent presentation. And very well said that when you access a difficult memory, when you deal a client, the abbreviation may come or sudden activation may come. I just invite her to just flow more throw light on how to deal when it comes suddenly as a reaction or sudden dissociation or sudden physiological reaction when you accept that part.
Thank you for that question, Dr. Sanjay. That's again a very interesting question. I think in my training, the two things that have really stood out in how we deal with sudden abreaction is that so I'm gonna say 3 points here. The first point is going to be around the concept of abreaction when we are working with traumatic memories and traumatized parts. Is that abreaction is not a reaction to the therapeutic process, because oftentimes that can be looked at as a side effect of the work, etc. Abreaction needs to be looked at as what needed to be expressed but could not be expressed. So abreaction is really sort of the impulse that got locked in time. So that's one thing. Now, how do we deal with that? Part of it lies in the phased approach that I spoke of, and because complex trauma, without the phased approach can lead to a lot of this sudden release or abreaction. It can be problematic for the client, as well as it can be difficult to contain during the therapeutic encounter. So, which is why the phased approach is in place when we sort of build resources as we go. So it kind of goes hand in hand. We build resources, we do a little bit of the trauma healing. Again, we build resources, so we kind of weave it in. When we are doing that, we are creating more space for the abreaction to happen within the safe boundaries of the therapeutic environment. The second thing that is important to understand is that one is this sort of this phased approach. The second thing is that the therapeutic relationship itself needs to be like the vessel that contains that abreaction, because it's the relationality, it's the relational safety also of the therapeutic space, and how the collaborative courage and the collaborative stance that therapists and the client are taking, that becomes the vessel that contains the abreaction as well. So oftentimes when that sort of a really intense abreaction is happening, therapist needs to embody the courage that is required to stay with that. So it's also about the therapist having enough ego strength to show up during the most vulnerable times when the abreaction is happening. Or when the client sometimes, or different parts of the client, feels not yet ready to sort of go towards that, I might say something on the lines of, what do we need to get there? Or, do we feel brave enough to go through this together? This we-ness, this sort of, collaboration that we are inviting, and it's no longer about them suffering alone. It's about A, being witnessed, and B, being resourcing together, that builds the capacity for going through the traumatic fall and the abreaction as well. So this is something that has come up many times in my trainings and my supervision spaces as well, that resourcing is not just about the client's resources. It's about shared resources that the client and the therapist are pulling in together. So relationality is one of the most important crucible for the abreaction to happen. I hope that answers your question, Sanjay.
Not a question, but Sanjay, what we talked about, expansion of the ego boundary of the therapist and merging of the ego boundary of the client, that's relational. So then it becomes work of both together, not individual. So that helps. Wonderfully explained. Thank you.
So, as you were speaking about this ego expansion, and as Sukanya was speaking about the inner resources part, inner resources of the therapist as well as the client, right? So it is often seen that when therapists lack the necessary inner work, or as Sukanya would put it, as inner resources, the complete integration and the complete process of the trauma work cannot be successfully done, because there is a lot of counter transferences happening, and even the therapist's inner ego states might get activated. So it is really important that we all keep doing our ego strengthening, our own inner work and inner practices before we actually jump on to managing trauma for our clients.
Yes, that will help ourselves and that will help the client also.
As
That
well,
is,
yes,
it's
yes.
a shared thing that the issue or the resources do not remain to me or to client, common resources.
Yes.
So that
But sir, one more thing, the child who is dissociative, having more of adaptive and avoidant behavior, they have very poor resources. And even family members are not as a resource person. They don't have any internal resources, and memories are very strong as intrusive memories which are there here. And when such thing comes, they are often activated and chronically activated. They don't find any safe space in their body also. So how to deal with such condition when everything is negative for them and they are totally avoidant? They are either more working with their gadgets only, and even they are not relieved in some of the severe dissociative traumas.
Allow me to answer that question, Dr. Sanjay. That's a wonderful question. Thank you for asking that. I remember for one of my students, supervising one of my students for their fieldwork, and they were going to an organization that was working with commercial sex workers. And when working with that population, they were finding it increasingly difficult to access a safe space. Because for commercial sex workers, the safe space doesn't exist in their immediate environment, it doesn't exist inside their body, it doesn't exist inside their mind. So, where do we access that safe space? Interestingly, what we found is that the safe space existed in the future of their children. So, where the resource exists, again, is something that surprises us in the work, and it's completely subjective. We cannot predict where the safe space will be found. Can be in the body, it can be outside. I remember a client I worked with for whom the safe space was inside a black hole. They were so unsafe in anywhere in the world or even in the universe. It's only inside the black hole that initially he found safety. So the way I look at it is that it's also about our openness, about wherever the client finds that safety, and it can be in a time frame, it can be in a space, anywhere at all. We can start with that. Drops of safety over time will also bring in those safety, and oftentimes we might not see immediate change in the autonomic energy, or we might not be able to create immediate safety, but we work with pockets of safety. So few seconds of safety is what we start working with, and we slowly titrate that to bring up more enduring states of safety in the child or individual. Again, it's like I said, that it's very nuanced and very complex, because there are no one size fit all answer for the different kinds of presentations we see. And as Nidhi was also talking about it, that in internal family systems we have this approach of one is sort of directing the individual to have their own self as the healing, the center of healing. But sometimes, like you said, that it may be a child who doesn't have almost nil resources. We're looking at developmental trauma where there is absolutely, the brain doesn't have a template of safety. So sometimes with such brains, I might even start working with more brain-based ways of instilling safety. So neurofeedback or biofeedback can sort of give the brain that template of safety, and then I work on it from there on. So what happens in IFS also, we say that sometimes if the individual doesn't have the capacity to regulate themselves because they don't have a good enough self or that regulating center, the therapist self becomes the source of the stability and the safety. So that's not the end state of therapy, because you want the patient's self, or even if it's a child, their self to sort of develop those resources. But at the beginning of it, when there are lack of resources, lack of internal resources, we can use external resources also for bringing in that safety.
Excellent.
Yeah. So I would like to share here, Dr. Dayal sir shared a paper with me, and I was discussing one of the cases of ego states, and he suggested it was a very similar case where this girl was not able to find any sense of safety with parents or whatever, and Dayal sir was explaining it to me how in some of the cases they introduce a fictional imaginative parent, but it can create disassociation as well. So I didn't go to that path. But then I went back to Dr. Jansel's book on past life regression, in which he has explained to invoke some being of light or some deity if a person already has a belief. For example, I remember a girl from a Bengali family who had a bad experience, childhood sexual abuse experience, and she was not religious, but she believed that yes, there is Devi Ma. That was her belief system. And so in that process, I asked her, ki, find a safe place. Where do you see yourself? And she said she's sitting in front of the temple, Devi Mata ka temple. And she said ki Devi Mata is blessing me. So at that point of time, I invoked that presence as her safe space, that she's providing all the nurturing which she lacked. And her issue was also that not that the trauma happened with me, but why didn't my mother see it? It happened under her nose. Why didn't she save me from that? So I use that imagery. So sometimes I find that using a client's belief system, not we don't have to introduce a new belief system, we don't have to introject something new as a hypnotherapist, but if they already have an existing belief system, we can draw a sense of inner being who's all powerful, all compassionate, and they do find a sense of relief and a safe space there as well. Sometimes this can also work.
If there are any other questions.
There is a question from Sukanya Haldar. I want to know whether caregiver or family members are involved in therapy session along with the person.
Yeah, I think it depends on a lot of factors. It depends on the age of the client. It depends on what kind of complex trauma we are looking at. Because one of the most important issues or factors for therapy to work is the collaboration with the client. Because if you're dealing with someone who has been chronically disempowered and chronically robbed of their agency, and then the same therapist sits for family sessions or group sessions with the family members and the individual, it may rob the therapeutic space of the trust that is essential. So it will depend on that strategizing and what approach will work best, whether it's another therapist who can work with the family, or whether it's the same person who needs to address that. The other aspect of it is also about therapist factors, which means that we're also looking at secondary traumatic stress. We're also looking at therapist burnout and the kind of resourcing that might be required on the therapist's parts to be able to hold space for both the individual and the family members. So we are humans, right? So we have only this much capacity. So it's also about really appraising our capacity for that and not taking off, not biting off too much what we can chew. So it's also about that really assessing what this might involve. And of course, the most important part of it is permission from the person that we are primarily working with. Without their permission, as a trauma therapist, I would never go with any prescriptive line of therapeutic intervention, whether it be family therapy or couples therapy, unless the person gives me express permission. I will sort of not venture into that.
Thank you, ma'am. I think there is one more question. If the perpetrator should be, I'll just read it out. I think Dr. Rajiv's question. What about pardoning the perpetrators of the crime during hypnosis? This is the question.
Yeah, I'm curious to know a little more about that. If you can maybe explain a little bit. I think he wants to be unmuted.
Yeah, Manisha, can we unmute her? Rajesh, sir, please unmute.
Yeah, now unmuted.
So you're still muted.
Yeah, am I audible? My question is, madam, after, like you were telling, you asked the person to imagine, you would like, how would it be to imagine the experience what the person had during the trauma? And then if we are able to bring it to get the expressions, the worst part of it, and to tell her that she did not feel, she or he need not feel ashamed about what happened to them. And actually, the fault lies with the perpetrator, and it is he who is going to, he or she is going to get the what you call repercussions, and that it is better for her to pardon, her or him, to pardon the perpetrator. Like you said about the slide, having it on a slide and moving it back, how will this kind of thing work in the mind of the person who has undergone the stress? This is one question. The second part of the question is, in hypnosis itself, if we succeed in making the client write a letter, exactly what all he underwent, by distortion of time factor, he or she is able to do a lot in a short time, and then the letter is torn into bits that he has pardoned that the person who has done that. And with this, the whole story ends. That the story of the trauma, what is in the deep long-term memory, is burnt off. And in order to see that this is fulfilled, what our speaker yesterday had mentioned about the key, Q, and then when he comes up, ask him what is the time. When I tell you what is the time, you'll go and write in your board my name and address. So with this, you are reinsuring that what you've done is going to work all right. And then you keep him under observance. What do you say about that, madam? Does it make any sense to you?
Thank you for that question, Dr. Rajiv. So, the way we use hypnosis in trauma-focused work is, like I said, that the approach is slightly different because we are working with individuals, especially if you're working with complex trauma and dissociation. So we are working with individuals who are deeply disempowered. So anything which is prescriptive, anything which is a suggestion, anything that is forced may be inviting other paths which sort of feel deeply problematic about that. So even within the sort of similar structure, we might not invite the client to pardon or sort of do any corrective action which is suggested by the therapist, but we would check in with different parts. What do the parts that are deeply traumatized need? And again, there is an element of surprise that always comes out there because with many individuals, what seemed to me as a therapist at that point of intervention, what seemed to me as, okay, they need to pardon, but what seemed like the healing moment was not the act of forgiving or pardoning, but the act of letting go or going away from there. Or, another regulated adult saving or rescuing that child part. So it may have nothing to do with the forgiving or the pardoning, which is why we say that this healing element or what is just right for the traumatized parts is deeply subjective, and it needs to come from the client. It needs to come from the traumatized parts, and we need to trust that part's wisdom. We need to trust the need that part feels. So again, we move away from being prescriptive or introducing any sort of suggestion that might be something that other parts view as problematic. And that can lead to deep fissures in the therapeutic relationship as well. So we are very, very attuned to what might feel, another level of traumatizing, because parts might not be ready to forgive at all, or parts might not be ready to let it go. And we need to go with that rather than be prescriptive and against it. I hope that answers your question. You're muted, sir.
Yeah, ma'am, we have, yes, ma'am. We have, I think, one new question. Manisha has asked, and does trauma healing works more effective, like peeling onion skin or directly moving to the core event that is creating the distress? Should we move like slowly or directly to the event?
Yeah, in trauma work, we say slow is fast. So the pacing is entirely dependent on the system and whatever pace. So sometimes when people come to me for therapy work, they often ask how long is this going to take. So while I might give them a ballpark figure of, let's say that it might take 1 to 2 years, but it really depends on each system. There are individuals that my supervisor says that you need to work with them lifelong. So I prepare myself that with some individuals I need to support them lifelong, and with some individuals they might come to us with sort of lot of work, lot of inner work that they have done by themselves. They have read stuff, they're already on the path to healing, and they have a lot of resources that are accessible for them. So for them, I might not, we might choose to not spend a lot of time in the stabilization, the first phase, and directly go into the healing part of it, the core healing part of it. So I would say that it entirely depends on what system you're working with. But the experience and the guidelines that I spoke of talks about how with complex trauma and dissociation, the pace needs to be slow. And we need to start with creating a safety net. We need to start with resourcing the personality and then going into the deeper end of it.
Okay. Ma'am, there is one more question by Shikha. She has written this cutting cords, but Shikha, are you there? I think what she meant to ask is that there is a imagery used sometimes that you're cutting off all the energetic cords with that person. I think that is what she means. She has just written one word. Yeah.
Yeah. So yeah, we are assuming that that might be referring to that metaphor. Again, in a very we might put that forth in an invitational manner. So again, language. I wonder what it might be like to cut some of the cords. Is that something that we can go with? So with the use of invitational language, we might suggest some things, but in a very tentative manner, and seeing really tracking the individual as well, what's showing up in their systems, what's showing up in their non-verbals. Are they looking like some parts are feeling disrespected, some parts are feeling unseen? So really sort of keeping that attunement on even while we are suggesting some of these things. Yeah, I think the last question is very, very interesting. Of course, there's a lot of literature on secondary traumatic stress and vicarious trauma for the trauma therapists. There are wonderful articles that are written on how the transference and the countertransference works out. Judith Herman herself has written about the transference and countertransference process and how that really weighs on the trauma therapists and how we can deal with that. But one thing that I keep hearing from spaces I learned from, and also I keep saying this to my students as well, is that you need a village to do this work. So while your clients need you, you need a village to support you. So one, you need supervision spaces. Sometimes a single supervision space is not enough. You need multiple supervision spaces. You also need your inner work, like Nidhi was saying. So really getting to know your paths, doing the work with your own internal system, and having your resources constantly, because we are the tool, and so we need to keep the tool sharpened. So constantly investing in self-care and putting ourselves first. A lot of that, without self-care, this work sort of falls flat.
One last question. So the question is, there are some non-responding cases who are having deep state traumas. There are some familial interpretation, generational interpretation, what we intergenerational trauma. And now it is said that more of epigenetic influence is related. Can we do something for these people like OCDs running in families or complex traumas running in families for a year together?
Yeah, again, a very interesting question. And of course, this is a population that we see that show up with a, very, very complex traumatic stressor. Because when we ask that question, oftentimes in therapy, we ask this question, where do you feel that in your body? And then they might not be able to sort of place it in the soma, and they're often sort of interpreted as coming from just outside the body. And they might even interpret it as when we are tracking parts. I remember a client I was working with yesterday itself. I asked this question: what does this voice sound like? We're working with a part. Does this voice sound familiar? And they were not able to place it. Yeah, it sounds familiar. I don't know where it's coming from. can you feel it where it's coming from, inside the body or somewhere outside? And they were not able to place it. And then we were wondering together, does this sound like an ancestor's voice? Does this sound like anyone outside the system? And what came up again surprised me, because this work is so full of surprises. And the answer that came up was that this was like a conglomerate voice of individuals who are working with social justice. So that was the voice that it was coming from. So it may not, we don't know where it may come from. We don't know how and what has been internalized as a part. It can be a voice of an ancestor. It can be the voice of a parent, a spouse, a friend, a sibling, or even somebody that they're coming across in social media. So again, being very open. And what we typically do in these kind of situations is that we are looking at the intergenerational trauma or the ancestral trauma, or I think there was another question on the chat which was around intrauterine trauma as well. So we look at these parts also as very internalized ego states, and sometimes we say that these are ancestors who are residing in one part of you, and they have a voice, and you make contact with that voice, and you have a conversation with those states. So the answer lies in collaborating with these parts and not looking at these parts as parts that are coming in the way of life only, and really sort of collaborating with the parts and being open to receiving their message, their wisdom. So if I'm working with a part that has come from the intergenerational transmission, I'll be open to ask questions such as, I wonder if they have a message for the system. I wonder if there's something that they want to leave behind as a legacy. So in IFS, we call these as legacy burdens, essentially parts that are carrying the legacy from previous generations or, previous times. Or these can be, from Jung's terminology, these can be parts that are really coming from the collective unconscious. Some of these parts are accessible only during dreams or sleep. So some wisdom or some generational part sort of comes up only in the dreams of certain individuals. So so likewise, there's a lot of creative work possible there in terms of how we access these parts and how we name them and how we are open to receive their messages and wisdom. The bottom line of that is every part, no part is a bad part. All parts are working for the system, and we need to just ensure that how do we bring that part online and tap into their wisdom. Every part has their own wisdom. So how do we work with the wisdom of the soma or wisdom of each of these parts? Thank you. That was a wonderful question. Thank you for giving me the opportunity to address that.